It's another day with the physicians where your health is our business. The growth spot the end. So you are not going to take some drastic measures. But a 10-year-old coming, pressure is high. But also to know that not only when your pressure is high that you have glaucoma.
And I don't know about any other one, but what is low?
You're welcome back to the training of your regular program. Diabetic retinopathy is a complication of diabetes caused by high blood sugar levels, damaging the back of the eye, which is the retina. At first, diabetic retinopathy may cause no symptoms or only mild visual problems, but it can lead to blindness if left undiagnosed and untreated. It is the most common cause of new cases of blindness among people within the age of 20 to 74 years of age. On your regular and favorite health TV talk show, The Physicians, our expert will be educating us on the symptoms, diagnosis, risk factors, causes, complications, and of course, the management of diabetic retinopathy. It's another interesting episode on your regular and favorite health TV talk show, The Physicians, where your health is our business. We will be talking about diabetic retinopathy, a medical condition that a lot of people are not quite aware of. I remain Dr. Memuna Yusuf Kadri, and of course with my co-host,
I'm Dr. Maxina Agberie. Welcome to The Physicians, where your health is our business. Let's take a ride on our diabetic retinopathy.
So we're talking about diabetic retinopathy. It sounds like a Greek word. Even me being a physician, like diabetic, okay, I know now. It's all sugar, is that what they say, right? It's sugar in the body. So which one is the retinopathy?
Retinopathy, the reti that is there. It's not a reti. Reti that is there.
So that is where information is key.
Disease condition.
Yes. Meaning, that means the retina is the part of the eye.
Yes.
How many people know that the eye has retina? So, it sounds so Greek, but it's such a dangerous medical condition.
It's actually a complication of people living with having diabetes.
We have an interest, and of course, if you are regular with the physician, you must have seen her over and over again. We'll be right back after this time out. Welcome back. If you're just joining us, just remember this is your favorite and most important health TV talk show on your screen, The Physicians. And we have our lovely guest with us right now in the studio. And she is no other person. If you've been a regular with us, she is the amiable and beautiful Professor ADEOLA ONAKOYA, a consultant ophthalmologist with Lagos University Teaching Hospital and a lecturer with the College of Medicine, University of Lagos. Hi, Prof.
Hi.
Anytime I see Prof, I'm like, thank God, I just need to be this Prof. Oh, these are the professors of the 21st century, always radiating.
Thank you for having me.
You know, we are talking of something not so...
Yeah.
It's interesting, but you know when you say something is interesting in medicine, it means that it's a bad condition, right? It's not so pleasant. We're talking of examining, wish it for myself and for anybody.
Right.
And it's diabetic retinopathy. It's good we start on that knowledge background and overview of what diabetic retinopathy is all about.
Yes. Thank you very much, and thank you for inviting me once
You're
again,
welcome.
Dr. Agberi and Dr. Memuna. Now, diabetic retinopathy. Of course, we cannot ignore that word diabetes because that is what gave rise to the retinopathy. Retinopathy means that something that has affected the retina, which is that membrane in the eye, like a cellophane that receives whatever we see in the environment. So it means that you have diabetes and then it has caused some damage to the back of the eye, and this will result into some loss of vision. Now, briefly, let me say something about this diabetes. I'm sure we all know a lot about it, but it's important more than ever before for us to pay very critical attention to diabetes because the number just keeps rising. I mean, currently, by WHO figure, 463 million worldwide suffer from diabetes mellitus.
Wow.
And of these 463 million, averagely, about 35% of them would have some form of diabetic retinopathy. And you know, with diabetic retinopathy, it starts small. You have the mild ones, and then you have the very severe one that results into blindness. In fact, in the industrialized world, you know, diabetic retinopathy is one of the foremost causes of irreversible blindness. Yes,
wow.
You know, it causes blindness. And how does it do it? Well, you know, diabetes generally, I mean, people talk about problems with sugar, but it's not just sugar alone. The metabolism, it's all about, even the proteins, the lipids, everything is abnormal in people who have diabetes. And they then end up with a lot of problems because this sugar that they have in their system is so much, and it's causing a lot of problems to the tissues. For some of them, you know, we have two types. There's the type 1, type 2. Type 1, we say those ones, they don't have enough insulin. Insulin is what helps us in, you know, turning those sugar to useful substances in the body. But for some people, they have the insulin, but insulin is not effective anymore. Probably because you have so much sugar in your body, so the insulin just gets tired, is not able to do what is expected to do. So what then happens is you have loads and loads of sugar in your system, which is not even useful to the tissue, which is why sometimes you see diabetics, you know, they start losing weight and the blood sugar is very high. Yes, they have very high blood sugar, but it's not useful to the cells in the body. You know, it's just floating in the system. And what then happens with regards to the eyes is just like what happens in other blood vessels in the body, especially those tiny, tiny blood vessels. And wherever you have those tiny blood vessels, those vessels will be damaged. Those are like pipes that carries blood around the body. We have these tiny blood vessels. We have them in the eyes, we have them in the heart, we have them in the brain, we also have them in our kidneys. So anywhere you have these tiny blood vessels, that excess sugar tends to damage these blood vessels. And when they are damaged, they then begin to leak. You know, like you have the vessel, these are tiny wires, you know, because of the excess sugar, it affected some things, turned to alcohol, which now affects the integrity of those blood vessels. So then they then begin to leak. Start with an outpouching first that we call a microaneurysm in the eye. The moment you see that,
we are going through stages now.
Yes. I'm just trying to give a general overview. Of the pathogenesis.
Wow.
You know, so you then begin to have, it starts with an outpouching, which is very weak wall, and with time, this then degenerates further, and you then begin to have leakages, blood, so they begin to leak blood. So they leak blood into the vision around the heart as well, in the brain and in the kidneys. And in the kidneys, you know, that is very, very interesting that by the time they have that microaneurysm in the eye, they also have problem with the kidneys. Those are the people that when they come to see you, you check their urine. They may have sugar, they may not have sugar, depending on the level of control. But once that damage has started, you begin to see proteins in their urine. And you know, in medicine, when you check, you put in that sticks in the urine, and there is proteinuria. You're thinking, okay, probably this person has urinary tract infection. If there's no urinary tract infection, and it's not a woman who is menstruating, there's no other reason why you should have blood. So you need to think about that kidney. That kidney is complaining. That kidney
that's
is
a red flag.
A lot of, yes, it's a red flag. So by the time they have that, you see proteins in urine of a diabetic. Go and look in the eyes. You will see some level of leakages, and unfortunately, this leakage will be in that part of the eye that is responsible for sharp, detailed vision. So they become symptomatic. You know, they then tell you, it looks as if
I'm not seeing
I'm not seeing well. Some may even complain, it's as if I see floaters, you know, all these black spots in my field of view, which is the reason why all diabetics, if that is the only thing that one is going to take away from here, as a diabetic, you must have your eyes examined by your ophthalmologist or optometrist, as the case may be, who is trained in that, you know, once a year.
At least, right?
Yes, which is minimally once a year. It's not too much. And what they do is just to put some drops in the eyes, and then they are able to see if you are at risk of developing that diabetic retinopathy. And of course, you know, diabetic retinopathy does not just come upon everyone like that. There must be a reason, and the reason is if you're poorly controlled. But the other reason why people develop diabetic retinopathy is the duration. If you've had diabetes for like 20 years, you know, the vessels, the tissues are getting weaker, and then you begin to see some tiny, tiny leakages in the
Okay, Prof, we talked about, very interesting, we talked about mild, moderate to severe.
Yes.
Do you want to tell us about the different stages?
Yes. So let's talk about the stages. Now for the mild diabetic, it's mild non-proliferative, moderate non-proliferative, severe non-proliferative, and then we have proliferative. So basically there are two groups. Non-proliferative and proliferative. The meaning of that, when you start talking about proliferative, that individual has what we call new blood vessels, and these new blood vessels in the eye, you know, they're so delicate, they're so friable, they bleed, you know, at every opportunity. So that is a very advanced stage. Now for the non-proliferative, I mean, none of them is really good because they tend to progress. Especially as the time is going, and then if the control is not good enough. Now for the mild non-proliferative, that is when once you see a microaneurysm, that is a mild non-proliferative. And then we'll go on to the moderate stages that you now have more of this. You know, I said it's an outpouching, which is a microaneurysm. And then with time, this outpouching now begins to leak. And by the time it's leaking, you now have hemorrhages, which we call the dot if it's very small, or we might have it as a blot depending on the level where that bleeding is taking place inside the eye. Okay, so we'll talk about dots and blot hemorrhages, or even it's on the surface, you can talk about what is called a flame-shaped hemorrhage. So you have all sorts of bleeding inside the eye. So when the eye care practitioner looks inside the eye, he sees all these hemorrhages in the eye. And if one is unfortunate and it falls within that area, which is called macula, which is responsible for sharp, detailed vision, which helps us to see what we have ahead of us, then the person becomes symptomatic, by which time they have then developed what is called diabetic maculopathy. In fact, diabetic maculopathy is the commonest cause of visual loss in diabetics. And that area is the area that is for detailed vision. So one does not want to lose one's vision. You know, you don't want to lose your sight. So that is, so that diabetic maculopathy can happen at any stage, really. It depends on if you have just bleeding above the macula that is just trickling down, you know, so there's going to be a lot of swelling, there's going to be a lot of edema, you know, which is swelling in medicine, you know. So you have a lot of edema, and then you can also have thickening of that part of the macula, and then the vision begins to drop. So that is maculopathy. But the individual might be lucky, it's just some hemorrhages scattered all over the retina. And then if nothing is done, Then you have some exudation, which they look like yellow color. We call them hard exudates. You know, you begin to see them. But anywhere you see that hard exudate, it means there's a vessel that is still leaking. And that is why, you know, when that individual goes at that time, there are treatments that will be given, you know, to stop those vessels from further.
So, want to quickly go on the street with keeping up with the physicians. Let us hear from you, our viewers, what you know about diabetes first. And of course, a complication of diabetes, which is diabetic retinopathy. We'll be right back after this timeout.
Well, diabetes is generally known as excess of sugar in the body.
Well, according to my own layman understanding, diabetes is when you have excess sugar in your body system.
It can lead to death.
But it's not good for your body system.
It enables every other diseases to have a venue in the human body system. Yes, yes.
You know how to control your, not necessary, because even when we say sugar, even this bar, all these carbohydrates, these foods that we eat, they contain a lot of sugar as well. But all you need to do is to control it.
To stay away from sugary things.
Welcome back. I'm sure you all heard about, you know, our viewers, what we're talking about with regards to diabetes and of course diabetic retinopathy. And we are still here in the studio being schooled by Prof, you know, because even being a physician, anytime Prof comes to the studio, I'm very attentive because I know she's going to tell me certain things. I have to go back home, either I start implementing them or start telling people around me, you have to be careful, you have to do this. And Prof, we're talking about, you know, moving from the mild to the moderate, now the severe phase where that, you know, blindness is inevitable and the complications that comes with it. Prof, can you elaborate more, because we are still within the COVID period?
Yes. Well, I mean, there's no other complication that comes with diabetic retinopathy other than blindness. Lose vision, especially if nothing is done about it, because there is then a lot of bleeding around. Some areas of the retina, they become, you know, they just die off because there's no blood going to them. And sometimes it won't just die off, it stimulates these new vessels, these friable vessels I was talking about, and that is what then would make it worse. You then bleed into other parts of the eye. And this can then, you know, after a while it dries off, and then you have like this hard tissue that can pull that sensory part of the retina, which is the receptacle. It just pulls it off and you have what is called retinal detachment. And that is what leads, you know, by that time you're already in the proliferative phase, which is the advanced diabetic eye disease. And by the time one has that, well, you can recover some vision after surgery, but that surgery you pay through your nose to get it done because it's not cheap. But what is cheaper is your control. Your control is cheaper. Lifestyle changes is cheaper. You know, looking at the diet, exercise is cheaper. You know, all these they are cheaper. But don't wait until when you get to that stage.
Yeah, is it reversible?
No, if you lose vision from diabetes, it's usually non-reversible. You know, what happens is those tissues, they just die off. But if it's still at the stage whereby what you have is just swelling, there's a lot of edema. You know, sometimes when we give injections, there are some injections that are given into the eye. They are called antivascular endothelial growth factor injections. Not just anti-VEGF.
You have talked so much about complications, and the other is the blindness that comes with it. Now, can we consider diabetic retinopathy a disability? Number one. Then secondly, for people who are diabetic, already diagnosed diabetic patients, and the ones that are not diagnosed, when they come, how fast do they progress into having diabetic retinopathy? Because for instance, those that have not been diagnosed, moving in our streets, not knowing that they are diabetic, of course, with the complications we're talking about now, this is definitely going to progress people having diabetic retinopathy. So how fast does it take to get there?
Well, it's actually difficult to say how fast, because some people at the time of diagnosis of diabetic retinopathy, all they just come to the hospital is, doctor, I'm not seeing well. Then you examine them and you say, this looks like diabetic retinopathy. By the way, are you diabetic? He'll say no. He doesn't know. And then you then say, okay, let's do a quick one. Can I have the glucometer there? You do fasting. Have you eaten? No, I've eaten this month. Don't worry, we'll look at your random. And then you do the random blood sugar.
Very high.
It's very high. That's how that individual knows he's diabetic. Now, that kind of person, he could have been going around with his blood sugar very high, maybe in the last 5 years. You know, some other people, you know, they have diabetes, they come, and then because of poor control, you know, they just go within 2-3 years, they begin to have this retinopathy. But, you know, we have some from evidence that people within the first 5 years, type 2 diabetes, you know, a certain proportion of them would develop diabetic retinopathy, especially those who are poorly controlled, especially those people whose HbA1c is higher than 7. You know, we don't want the HbA1c to be more than 7. Once it is higher than 7, of course, the rate or the predisposition to diabetic retinopathy is higher.
So our viewers, what is HB?
It's actually a test, you know, because blood sugar attaches to hemoglobin. So it's a measure of how much of sugar that you have attaching to hemoglobin. So if you have so much of sugar free that is attaching to hemoglobin, it means that you have so much sugar flowing in the blood. So that is why it's a good measure. It actually measures the level of your control. You know, people are very smart. Like diabetics, when they are going for their appointment, they behave very well. You know, they in fact, they may fast such that by the time they go to see their doctor, you know, fasting blood sugar will be normal, 2 hours postponder will be normal. But if you do their HbA1c, you know, which is a measure of what has been happening in the last 3 months, then you discover that HbA1c is like 10. So such individual is not controlled. So you then tell him or her that, look, you're playing with diabetic retinopathy, diabetic nephropathy, you know, that's the one affecting the kidneys. And if you are lucky, you don't have diabetic encephalopathy, you know, because they all move together. They all move together. So it's important for diabetics to ensure that the blood sugar is controlled, because there's nothing it does to the body other than to cause damage.
So, Prof, let's come to the management, because all this, they must say, this Prof has been dishing out this. Okay, now how do we now manage it? Of course, we know that controlling diabetes, if you have you are diabetic, is #1 standard. But what are the other medical management and, of course, surgery if needed?
Yes. Now, for people who have diabetic retinopathy, the first advice is good sugar control. Good sugar control. And then apart from that, blood pressure control. Tight blood pressure control. Your blood pressure must be normal. In fact, people who are diabetics who don't have high blood pressure, they put them on some groups of drugs, the ARBs, you know, they ask them to take it. These are blood pressure medication, but they have to take it so that it helps in opening up those blood vessels so that the blood vessels don't shut down. So tight blood pressure, tight blood sugar control, tight blood pressure control, and then even the cholesterol. Your cholesterol level must be within the normal range. So for you to be able to do this, it means you must have lifestyle changes, dietary control. You have to take less of carbohydrates, you know, you have to take less of it, you know, because when you have excess of it, you end up with problems. And so dietary control and exercise, that is on one side. Now, for somebody who has microaneurysm or even those dots and blood hemorrhages, well, what happens is, because you're seeing your eye care practitioner, you know, some can say, okay, come back in 6 months, let's see what happens. And if they see more of this bleeding, then they may give you an injection into the eye. That injection I talked about, because what it does is it reduces the inflammation, it mops up whatever swelling that you have so that you don't lose vision from it. Or sometimes, like if you now have some of these vessels, some of them are being shut off, maybe you've now done a test that is called fluorescein angiography, or you have done a test that is called OCT, we call it OCT, optical coherence tomography. It's a scan of the eye. you know, the inside of the eye. We see the pictures. So if you have swelling, if you have fluid in the eye, under the retina, it shows up. So you might need to have laser and to have these injections inside the eye. I tell you, these injections too are not cheap. And for some people, they may need to take this injection every month. You know, we give it inside the eye. We inject it inside the eye, like this eye model. We give the injection here. You know, so you put it inside the eye, right inside the globe.
Wow.
Yes, you know, because
and
we are targeting those
basis.
vessels. Yes,
For some
maybe
people.
for the first 3 or 4 months. Yes, for some people, depending on the severity of the diabetic retinopathy.
You've heard it. Over 463 million people are diabetic worldwide, and out of this, 35% of them we have diabetic retinopathy. I remain Dr. Memuna Yusuf Kadri, and of course, till next time, stay blessed.
So thank you so much, Prof, for coming on our program. And remember, I will always call on you. I say continue to follow us on all our social media handles, on Facebook, on Instagram, on YouTube. And if you've been part of this program and you have not even watched some other episodes, you can actually go on Facebook to go and watch it. If you want to be part of this program, that's just a click away. Just call us or send us a mail and you'll be invited. Stay blessed. I am Dr. Martina Adboye.
My name is Sheyi Do. I'm a consultant orthopedic surgeon, special interest in orthopedic oncology. I've just been on the physician where you get all your health information. We've talked about lumps and bumps, the importance of it in various parts of the body. Remember, if you pick any lump or any bump on your body, get it checked out as soon as possible. Early detection can lead to cure, and the chances of better outcome is always better with early detection and evaluation. Thank you.
To help children become heroes in society and to alleviate the numbers of problems that happen due to them not knowing what to do in these kind of situations.
Okay. So how do you plan on achieving the aims of the LIBO? So